Hi folks, this is Dr. Rob Sivers, and I am the Carb Addiction Doc, and as the final in a series of lipidology, cardiology, statin type drugs and statin thinking, this is the final video, and one of the things that perplexes me always is when you see a cardiologist, before you even walk in the door, you might be a delivery person, but they're talking to you about you need to be on a statin, and there's nothing that can dissuade them from that narrative. And yet, there are several things that they know about, that they absolutely know about. It's in their literature, FDA approved, where the drugs are far more effective at reducing cardiovascular disease than statins. And yet they will insist on a statin, and most of them have never ever mentioned this word. So there's a drug out there called Colchicine. Some of you may know it. If you've got gout, you've probably heard of Colchicine. But most of you, there's nobody that's watching these videos that doesn't know the word statin. And I bet you very, very few of you know the word colchicine. So the FDA a few years ago approved colchicine as a very powerful drug with a much higher risk reduction than statins for cardiovascular disease, for atherosclerotic cardiovascular disease. And you've seen this guy on this channel. I've got a friend and a patient by the name of Dr. David Nabert, who is an electrophysiology cardiologist. He's a cardiologist, and he brought this to my attention. I knew about and I use colchicine for my gout patients. I use it for inflammation, but I haven't looked at the association of colchicine and risk reduction for cardiovascular disease. And yes, you want to reduce the inflammatory response. You want to reduce the cause of the inflammation. But early on, as you are responding to this inflammation, why not? Let's consider and let's talk about colchicine and what it does and what the risks and benefits are. So in patients on a standard American diet, in patients with a significant, you've had a CAC score, now you've got plaque in you've got plaque in your blood vessels, or you've had a heart attack, you've had a stroke, you've had an event, and we call the intervention secondary prevention. So you've had an event, now we've got to reduce the risk of a second intervention, of a second event. And the FDA, as I said, has approved colchicine to reduce coronary artery vascular risk, CVD risk, at a level that is far greater than statins. So if you have positive cardiovascular disease and measurable inflammation, and this is blood work that we do, high ferritin or a highly selective CRP, C-reactive protein, above 2. Now, ideally, I want that below 0.3, which is an anti-inflammatory thing. But if you've got ongoing inflammation, and we can measure that with white cell count, we can measure it with ferritin. CRP is the one that the cardiologists use, and I think it's a valid number. If that's elevated and you have plaque, colchicine should be a seriously considered medication for a while to reduce that inflammation. And we're talking about something that is secret. Why? Because colchicine doesn't cost very much money. It doesn't make a lot of money for the insurance companies. It is ranked as the 184th most commonly prescribed drug, statins being right up there as number 1 or 2. Think that one through, because money. And I know I'm not that jaundiced conspiracy theorist, but that is a direct correlation, especially if you consider a significantly increased risk reduction versus statins. So what is colchicine? Colchicine actually comes from a plant, and we've known about it since 1500 AD. Okay? 1500 BC. BC, before Christ. Okay? 1500 years before Christ. Folks ate this for joint inflammation. It's one of the crocus plants. They used to consume it for joint inflammation. So what colchicine does is colchicine is a powerful anti-inflammatory. We go into the mechanism. And the most common use of colchicine right now is for gout, for elevated uric acid. So if you have an attack of gout, affects your fingers, affects your toes, big toe is the most common one, or if you have kidney stones, a lot of doctors like myself will use a short 2 or 3 day course of colchicine to reduce the inflammation from gout. But uric acid, which is a product of fructose consumption, carbohydrate, also results in a risk of gout and a risk of kidney stones, sodium urate stones. And allopurinol is one of the drugs that dumbs that down. So allopurinol is the preventive. Why don't we use colchicine that often as prevention? Although I do, because its drug range, its dosage range has to be very tight. It can have devastating effects when it's overdosed. So please, the more is better population out there, the more is better. A little bit works, I'm going to take more. Please do not do that if you're going to consider colchicine, because more can be very toxic at a high level range. But if you're in the 0.5 to 0.6 range, and at the end of this, I'm going to use Dr. Neighbor's dosing pattern to talk about it. But what colchicine does is it prevents inflammation of the joints. And so colchicine is a very powerful anti-inflammatory, primarily associated with gout use. However, vascular inflammation and a reduction in vascular inflammation is its primary effect. So colchicine significantly reduces the vascular inflammatory response, far better than statins. And it should be a go-to drug for secondary prevention. That is the most important consideration. So if you've got a significant plaque burden, if you've had an event, a stroke or a heart attack, colchicine should be a very serious drug at the top of that list until we get rid of the inflammation. Maybe together with an aspirin. And we have to shift our thinking of cardiovascular disease away from lipids and away from LDL and cholesterol toward inflammation. Once you consider inflammation as the cause of this disease, then colchicine falls very neatly into place. And in my opinion, and I'm going to modify my management, the combination for certain patients with high risk, a combination of a low-dose aspirin as well as colchicine at low dose is the healthiest combination, especially if you've had a stroke or a heart attack. Now, one of the interesting things is that colchicine also reduces amyloid protein synthesis. And for those of you who don't know amyloid is a protein replacement within organs when cells of those organs die. So we see amyloid in the pancreas in people with diabetes, type 1 diabetes. But the biggest tissue replacement by amyloid occurs in the brain, and we call that disease Alzheimer's. And so many experimental companies are producing drugs that block protein synthesis, that block amyloid protein synthesis. And the FDA has even approved some of these pathetically weak drugs. You've heard about them in Alzheimer's because they're going to make money, but they don't affect Alzheimer's. Because Alzheimer's is an inflammatory condition. And the amyloid is there to replace the death of the brain cells. And what colchicine does is it's associated with a reduction in amyloid. But it doesn't directly reduce amyloid. It reduces the inflammation, so there are lower levels of amyloid. But what they do, the pharma companies, they directly treat the amyloid, block the production of amyloid. But that's not fixing the inflammation. Colchicine does. Colchicine is also, so we've talked about it as inflammation in the blood vessels, the plumbing to reduce atherosclerosis. But colchicine also works very effectively, and attention diabetics, type 2 diabetics, colchicine works very effectively to reduce inflammation in the cells of your pulmonary veins, the blood vessel cells that over time will modify and become electrified. Those cells in your pulmonary veins can become electrified and have an electrical signal when they shouldn't have a signal that interferes with the normal signaling of the electrical system of the heart, and we call that atrial fibrillation. And colchicine also reduces inflammation in those cells and reduces the abnormal electrification of the heart and has an anti-atrial fibrillation effect. So the combination, and so where exactly does colchicine work? Well, colchicine specifically reduces activation of white blood cells, of leukocytes, decreases their activation, decreases their aggressive function, and decreases their adhesion to plaque. And if you remember, plaque starts out with a fibrin clot, adding platelets. Aspirin blocks that. And then the activated platelets bring white cells in, and the white cells bring macrophages in, and the macrophages bring plaque in, or lipids. So if you use an aspirin to block platelets, and you use colchicine to reduce that the inflammation and the activation of those white cells and the adherence of those white cells, you are doing two massive things to reduce clot propagation while not interfering with the clot itself. Because there are things like Eliquis that are factor 10A inhibitors that prevent the clot. Well, if I cut myself, I want a clot. And yes, ideally, I want activated platelets, I want activated white cells. But if there's a balance between reducing a cut from a clot, the clotting from a cut, and reducing plaque formation if I'm at risk for plaque formation, this is where that balance works. Where I can still clot off, or at least create an early clot for a cut, which is a one-time event. But I'm not having this ongoing massive anti-inflammatory response, excessive anti-inflammatory response occurring in my blood vessels that is going to kill me of a heart attack or a stroke. There's no right answer. It's not absolute. But that is what we do with people that already have inflammatory disease. So the baby aspirin shouldn't be taken by someone who's got no risk or low risk. Same thing with the colchicine. But if your uric acid is high, if you're pro-inflammatory and you've got plaque or you've had an event, the combination of aspirin and colchicine is highly recommended, particularly as a weapon against statins. So stop the statin and take those two meds. Just be very aware of the dosing, and low dosing is the way to go. So colchicine interferes with white cell adhesion, white cell function, and it also reduces the inflammasomes that put out all these pro-inflammatory cytokines. So it reduces the inflammatory risk. And so many people with cardiovascular disease, atherosclerotic cardiovascular disease, have high uric acid levels. High uric acid levels. And we see that even in our LMHRs. So there's that double benefit. So I become very, very gung-ho on colchicine, albeit my primary focus is to reduce inflammation, so I don't need any of those drugs. But if you already have the disease and you don't want to see propagation, this may be a better added strategy. Definitely, in my opinion, than the baby aspirin, and then under certain circumstances, the addition of colchicine. So, for example, I had a patient a couple of weeks ago taking his baby aspirin, but he has a huge burden. I think it was 36 or 3,700 CAC score, and also a burden of plaque in all of his vessels, in the carotids, in the vertebrals, and he had a small stroke on aspirin. Disease everywhere, and developed a small clot in the basilar artery of his brain. Well, perhaps if he was on colchicine as well as aspirin, that may not have happened. Now, the good news is they got to him early, they removed that clot, and he's got very little residual effect of that stroke. But it could have been catastrophic. And if he wasn't on the aspirin, he probably would have died or had death of his brain. But I'd like to put him, or suggest to him, I never put anybody on, suggest to him that we add colchicine to the mix. Now, he's also doing a wonderful job of reducing ongoing inflammation. Reducing ongoing inflammation through dietary changes, through lifestyle changes, which is the foundation. But because he's got existing disease, because he had a life-threatening event, the risk or the downside of colchicine, any downside, which is really from toxicity, is far more worth accepting for the massive benefit. So that's the way my brain works. And I'm not going to, he says no, I'm fine with that. It's a decision we make. But in order to say yes or no, you need the knowledge and you need the science, not the emotive thinking. I'm not going to scare him. I'm just going to say, hey, this is something we've learned. This is something you can add to it. Now, this from David Nabert. So this is a cardiologist's use of this medication. And in his population, he sees a lot of people that are not willing to go on a low carbohydrate diet. My population are all at least trying. And if you're trying but struggling, or if you say, screw it, well, screw it is not going to fix the problem. But what David talks about is when he sees a CRP, and we test CRP on everybody, above 2, and you have pre-existing cardiovascular disease, he uses a 0.5 milligram dose. Now, for gout, we use a 0.6 milligram dose a day. And that costs you about $20 a month through something like GoodRx. About $32 at CVS for a 90-day supply. So it's not expensive, just like baby aspirin is not expensive. Statins are far more expensive, although they may be covered by insurance. So if you meet the criteria, secondary prevention, significant plaque burden, elevated CRP, then adding colchicine to your aspirin, and ask me about it if you're a patient of mine, may be a very effective, safe, non-toxic, non-harmful way to go because of the statin profile of harm and less effectiveness. And under these conditions, you can even go to lower dosing. So as your CRP improves, you can go down to taking half a tablet, 2.5 milligrams every day, or maybe even doing it Monday, Wednesday, Friday, because the benefits occur at a very low dose. So that's David's strategy. I found that half a tablet on a weekend strategy works pretty well in people who struggle with compliance or people who do not have a very high CRP but have a high plaque burden. So I think the value of preventing clot in a safe way, where we know it's effective, it has value in people with pre-existing disease. But if you've got a 0 CSC score like me, don't even go down that pathway, but work really hard on preventing inflammation, not smoking, not having insulin resistance. And that's where the GLP-1s and some of the diabetic medications may have greater advantage. But you need to know about colchicine. You need to know about its effect. You need to ask those questions. And the final thing I'll tell you, this is the paper. The paper published in the Journal of the American College of Cardiology says low-dose colchicine for secondary prevention of coronary artery disease. And I'll give you the summary. Inflammation assessed by means of high sensitivity CRP, hsCRP, is a more powerful determinant of cardiovascular death and all-cause mortality than low-density lipoprotein, LDL-C. So hsCRP, a marker of inflammation, is more predictive of cardiovascular death than LDL, which is what every cardiologist is measuring all the time. That's their starting point. And these are cardiologists. Several therapies that target residual inflammation, residual inflammatory risk significantly reduce vascular event rates. For coronary artery disease, patients already taking other medications, including statins, low-dose colchicine, and I'm going to paraphrase here, may be a very healthy, very effective, and this is coming from me, Robert Cyrus, not them, because they use it on top of a statin, a very, very healthy alternative to a statin. And the low dose is 0.5 milligrams orally. And this has been shown to safely lower major adverse cardiovascular risk by 31% amongst those with stable atherosclerotic disease and 23% secondary reduction if you've had a heart attack. So if you've had a heart attack, your risk of a second heart attack is lowered by 23%. Basically 1/4 reduction on colchicine without any other changes. You then change your diet and you massively reduce that. These magnitudes of benefit are larger than those seen with lipid-lowering agents. Lipid-lowering and inflammatory inhibitors are not in conflict, but are synergistic, and I disagree with that. I disagree with that statement. That's where they and I disagree. Colchicine is a replacement for statins, not to be used with a statin, in my opinion. But in June of 2023, exactly a year ago, the US Food and Drug Administration, the FDA, approved the use of low-dose colchicine to reduce the risk of myocardial infarction, stroke, coronary revascularization, and cardiovascular death in patients with established atherosclerotic disease or multiple risk factors for cardiovascular disease, including atrial fibrillation. It's in the College of Cardiology. They don't talk about it because it doesn't fit their narrative that inflammation is the problem, not lipids. If I've made you think, if I've given you new knowledge, and I know I have, I've done my job. Leave $1 in our PayPal account. Till next time.